Ready to go? Thank you very much. Yeah, a very warm welcome, everybody. We are in exciting times, a very dynamic situation with respect to systemic therapy in hepatocellular carcinoma. I'm Peter Galle from Mainz, Germany, and I have a splendid faculty here. Dr. Lipika Goya from Stanford and Dr. Ahmed Kaseb. They are both colleagues with a great track record with respect to publications and involvement into clinical trials, and certainly an honor to be with you, Lipika and Ahmed. We are proud to present this session and thank PeerView and Blue Ferry, the Adrian Wilson Liver Cancer Association, for providing this session. And we have educational grants from AstraZeneca, BMS, and Merck supporting this endeavor. Please complete the pre-event survey and look out, there is more to come. There will be a barcode presented where you can get connected, can pose questions and answer to our polls. Same is true for the virtual learners. There will be polls on your screen. And all involved are questioned to support this situation, the ongoing discussion, by posing questions and get actively involved. You get some reward for that. There is, at least for the in-person learners, $50 gift card provided, and it actually pays attention very much to your activity. The more active you are, the more questions you pose, and the more you get involved in the polls, the more likely you get a gift card. So here's the QR code, and you're happy to use it. And then these slides, which we are going to present, and also some practice ads, are available, and you can download them after the event. We have several goals for today. Of course, we want to share the recent developments and the ongoing activities in hepatocellular carcinoma treatment. And this is actually coming down then to very individual skills and strategies which go beyond what we see in clinical practice guidelines. It's fair to say that probably only 50% or so of patients are treated according to guidelines, and this is not because guidelines fail. For individual situations, not necessarily the evidence is always there, and that has to be created in a multidisciplinary team setting. And that's what makes hepatocellular carcinoma treatment so challenging, bring all the people involved together. I'll get started with a couple of remarks in terms of the background of the disease and also the recent developments. It has always been claimed that the incidence and the mortality are extremely similar, telling us that unfortunately, if there is hepatocellular carcinoma diagnosed, the likelihood to die from it is very high. We are concerned that we increasingly see liver cancer in younger populations, and predictions show a rise for the future, to some extent driven by metabolic dysfunction-associated liver disease, MASH, and that is in the end requiring new options for treatment. Fortunately, we have seen, if you take this timeline of the last 8-9 years, quite a significant development, in particular with respect to immune therapy. Monotherapy gave signals in individual patients, actually very strong signals, but statistically not satisfying. The game changer then was in 2020, the approval of Atezo-Bev as the first combination who entered the market. And that was followed by other combinations. The Himalaya protocol developed Durva and Tremi, CTLA-4 and PD-1 ligand inhibition. And very recently, and we will capture that, we saw the approval of another CTLA-4 PD-1 ligand PD-1 inhibitor scheme, the Checkmate 90W, which we presented last year at this meeting at ASCO. And then there are a couple of downsides which need to be addressed. According to a SEER Medicare study of last year, it was apparent that still a large fraction of the patients receive TKIs, although this is not the preferred option for systemic treatment. And then another aspect which is critical, we see only a very small proportion of the patients receiving first line to get switched into second line. That's what we need to debate. But you can actually go even a step earlier and see what we achieve when we do screening. We should never forget these patients are in a way well defined. All these patients basically have underlying liver disease, so we know who is at risk, but we are not very good at screening, and that's something which we will address during the presentations, because besides the aspect that you can treat a tumor, it's of course much easier if you treat early or if you avoid a tumor. And then never forget, we are not treating a tumor. We are treating a patient with a tumor, and it's very important to see that here are patients' voices heard, and here are in particular Blue Fairy as a patient advocacy group where patient group supports clinical trial information and latest news about liver cancers are captured, transformed into readable information, and involving the patient in what is also increasingly done in multidisciplinary teams, because in the end it's about the patient and the quality of life of a patient and not just a shrinking tumor. So let's get started with the situation where we stay today in terms of treatment. Most of us would accept the BCLC scheme, Barcelona Clinic of Liver Cancer staging scheme, as underlying basis to make stratification and prognostication possible. The beauty of BCLC is that it's very clearly giving a prognosis prediction, and that is in the end something which tells us that we are indeed not performing very well. If you see the fraction of the patients diagnosed at an early stage here in green and in purple, then you see that 1/3 or so in Europe and North America are captured at a stage where early or very early, where curative intent intervention is possible, but the majority, unfortunately, is diagnosed at a late stage in a palliative setting. This does not necessarily have to be the case, and the example here is Japan. Here you can see that only a very small proportion is in advanced or end-stage disease, so the majority of the patients are captured early on, where a lot more is possible. Deepika and Ahmed, why are we performing so poorly, and why is Japan doing better than we do?
So I think one of the main reasons in my mind, in the US here, is the fact that most of the patients with those risk factors that we know in clinic are really under recognized in clinics. So unless you're a hepatologist, you have your patients following for known liver disease, hepatitis, or cirrhosis. Primary care physicians really are not trained well enough, and that's our collective, problem, that we don't train them enough to recognize those patients, especially with the non-hepatitis metabolic syndrome patients. But it is changing. I know that the societies now, especially liver societies, are raising the awareness about catching this mast cell, and so that's, in my mind, one of the main factors why we're not diagnosing them early enough. What do you think, Lipka?
Yeah, I think one of the things that might change this is if we're able to develop blood biomarkers for patients. They won't have to come every 6 months to get their ultrasound and their blood tests. I think if we're able to develop blood biomarkers to do early detection in HCC, I think we're going to get closer to Japan's numbers.
Yeah, I guess we came from the old days where liver disease was a guilty disease. You drink too much, you eat too much, and untreatable disease. You can't do anything. And now we realize there are many reasons to develop that cancer, and also there are options to get treatment. So I think a more positive approach is probably helping. It has gotten into a very fine-tuned arrangement when you go through the different stages and see what is offered. And today we will concentrate on this part here. And in the recent update of the BCLC scheme, that was from 2022, we had 2 combinations, and now the updated versions of the relevant guidelines also include the CheckMate 90W data on nivolumab and ipilimumab, and we will show you the reason for that option. And then what will later be sort of complex is what do we do in second line, because here we do not have so much evidence. I'm showing here a patient of mine. You see there is a large tumor comprising most of the left lobe. And this patient also showed a high alpha-fetoprotein, so it was an undifferentiated tumor. There was a portal vein thrombus, and with macroscopic vascular elevation, it was clearly advanced stage disease. Keep that patient in mind. It's clearly advanced stage disease, prone to systemic therapy, and we will later show what we did in this particular case. However, what would we recommend to do in any case is that you consider those patients in a situation where systemic therapy is the mainstay. First of all, for immunotherapy. Immunotherapy is superior, and only those patients who are inappropriate for immunotherapy should not see it. And then we have the aforementioned 3 combinations, atezo-bev, durvaltremi, and ipi-nivo. A small proportion of patients, maybe monotherapy can be applied, and only in those where immunotherapy is not relevant, we would use TKIs, which we consider in these days more toxic. The basic data set, as I said, the game changer was the IMbrave 150, the combo of atezo-bev. You have seen that, I guess, many times. A very nice and very early from the first imaging on separation of the curves, which is then maintained over time. And these 19.2 months compared to sorafenib 13.4, almost half a year in gain in overall survival, was really making a difference, which we haven't seen so far. Accompanied by 30% objective response, duration of response of 1.5 years. That was convincing evidence of combo working, immune combo working in hepatocellular carcinoma. The next combo was CTLA-4, only single dose, tremelimumab, together with durvalumab in the Himalaya protocol. Here the data were in absolute numbers, a little less impressive, 16.4 versus 13.7 with respect to overall survival. But again, a nice separation of the curves. Here it takes 6 months until they separate, but then this data set is quite mature. We have seen the 5-year follow-up data, and you see that there is a relevant proportion of patients even after 5 years, almost 20% alive, which is really showing that some patients are benefiting in a very significant way. And the efficacy, and that's the beauty of these immune combinations, is at least for the most part accompanied by a favorable safety profile. If you take the IMbrave 150, sorafenib results in diarrhea and hand-foot skin reaction, which is meaningful with respect to quality of life and well-being of a patient, whereas hypertension and proteinuria, the side effects sticking out for atezo-bev, is nothing really impacting patients' everyday performance. Requires attention, yes, but they are feeling better. In the same situation is true for Himalaya. Again, hand, foot, skin, diarrhea sticking out, and the distinct side effect profile in that particular combination was very favorable in terms of immunotherapy. So we have seen at that stage a year ago 2 trials running against sorafenib, showing convincing evidence that the immune combo is better with respect to overall survival, with respect to objective response, 30%, 20%, and 1.5 or almost 2 years of duration of response. And what we are adding this year is the Ipi-Nivo combination based on the CheckMate 90W presentation. 90W was using a high-dose ipilimumab 4 times, and in most patients that was actually applied 4 times, accompanied by nivolumab treatment, running against investigators' choice, sorafenib or lenvatinib, which in the end was lenvatinib in 85% of the patients. Overall survival was the primary endpoint, and a couple of secondary endpoints. Very mature data set last year already with 3 years of follow-up. Here we had an interesting Kaplan-Meier situation, which showed a non-proportional hazard situation in the beginning, but then a very good separation later on. 36% of objective response and 30% of duration of 30 months of duration of response. So clearly a situation where a large proportion of the patient is actually benefiting for very long term. I always like waterfall plots because they capture the individual development and the depth of a response. What you see here is that actually the percentage of patients who are showing some sort of regression is basically the same, but the extent of regression is quite different in favor of the Ipi-Nivo group compared to the mostly lenvatinib group. And that is meaningful. It's translating into overall survival. This curve here shows the survival in correlation with the best overall response at a 2-year landmark. And you see that if you take those patients with an objective response, CR and PR, after 4 years or so, 3-4 years, then you realize that the vast majority of the patients are alive. And interestingly, even if the best response was progressive disease, so basically no response, there's even a difference, 16 months versus 13 months in the comparator. So apparently, even in a progressive patient, the immune stimulation is resulting in some sort of benefit. There were no relevant differences with respect to patient subgroups, something which we have been discussing over the years many times. Etiology is always sticking out, and the question, what is the outcome in immunotherapeutically treated patients if there is fatty liver disease? But you can see that apparently all of them are benefiting. Here in this setting, Hep C is showing the best hazard ratio. That's quite different to the Himalaya trial. It tells you basically that you can't compare trials, and the inclusion criteria may be more relevant than the response with respect to outcome in the end. Is playing in your everyday routine etiology in any way a role, Lipika?
No, overall, when I see someone has hepatitis B, I'm hopeful that they especially will have a response to immunotherapy.
So you're still in favor of viral?
I'm still in favor of people with hepatitis B having a nice response to immunotherapy overall, but whether they have Hep B, Hep C, or they don't have viral hepatitis for any reason, still favor immunotherapy, and it doesn't help me choose between the 3 regimens.
So at this point, etiology does not play a role with respect to clinical decision making. Checkmate 90W also is not only effective, but there is a certain price to pay. Numerically, the adverse events are comparable, but they are apparently more severe in Ipi/Nivo because the discontinuation rate with 18% is higher than with 10% for the TKI. There's also a certain death poll, 12 versus 3, and most of them actually came from hepatobiliary disorders, and you see that this proportion is also more pronounced. Does that mean that patients with poorer liver function are not treatable with Ipi/Nivo? It's definitely not the case. We just had a recent presentation at EASL, European Association for the Study of the Liver in Amsterdam, where we correlated the outcome with the albigrade, albumin and bilirubin, as a simple and objective measure of liver function, grade 1 being good and grade 2 not so good. And what you clearly see is the prognostic relevance of this albigrading, because you can see that the OS in those with good liver function is with 35 months, much longer than the albigrade 2 and 3 patients. So it's absolutely prognostic, but it's not predictive of therapeutic outcome. The relative difference demonstrated by the hazard ratio of 0.75 is actually the same. So yeah, patients with poor liver function upfront, they perform overall worse, but they respond to therapy. And if you check the time to liver function deterioration, there's even a sort of a protective aspect to Ipi/Nivo, because it takes quite a while, and that might be the period where CTLA-4 is playing a role. But once that is over, liver function is actually quite stable. Conversely, in the TKI-treated population, it's deteriorating. So it's not that we cannot treat poorer liver function with this protocol. It's active. And for the long-term run, the liver function is actually maintained. Now we have 3 combos, and there's a lot more going on, has already been demonstrated or is coming up. There's just a few examples. We do have monotherapy data. Rationale 301 showed that tislelizumab is non-inferior to sorafenib. One could add durvalumab. In the Himalaya trial had been demonstrated to be non-inferior to sorafenib as well. We have now for already a couple of years camrelizumab plus rivoceramib. It's old enough that we already see at this ASCO real-world data, but has not found its way into approval because of manufacturing issues and toxicity. That probably will come. And then the Gemini platform is something interesting. These are bispecific antibodies directed against PD-1 and either CTLA-4 or TIGIT, another checkpoint inhibitor. So there is a lot going on, and that will stimulate the field further in the next years. There are modes of different application. Subcutaneous immune point check inhibitor have been demonstrated to be equally effective, at least for renal cell cancer. And we have approval both by FDA and by EMA for a variety of different checkpoint inhibitors, nivolumab, atezolizumab, and pembrolizumab. And that actually can make life a bit easier. It's faster applied, it's not requiring so much effort. So that is something which can be considered. I have to admit, I personally have no experience here. Do you? So, I mean, when we look what has happened in the field of chronic inflammatory bowel disease, there is clearly an advantage seen by subcutaneous application. We'll see. Maybe that is coming at a later stage. Now, let's get back to our patient, which you have already seen. And the question is, what is now to be recommended? We have already started the discussion about etiology. And of course, one might have a more complex situation with respect to therapeutic decision-making by making this an older patient, a bleeding risk patient, and so on. So that is telling you that we have an expectation with respect to efficacy of a treatment, but then also a very relevant basis for our discussion in therapeutic decision-making is the side effect profile and the toxicity. So here is a question in order to get you the $50 gift card or to speed the discussion. And please use the QR code to answer. You're managing a 64-year-old man with alcoholic cirrhosis, newly diagnosed with metastatic HCC, and EGD revealed an increase of bleeding. What treatment regimen would you now select for these patients? Would you go for PD-1 or PD-1 ligand monotherapy? Would you take this backbone of immune therapy plus VEGF inhibition? Would you do dual checkpoint inhibition, or would you do sorafenib monotherapy? So, of course, in these days, all these options are possible, are with respect to approval status an option. But here we talk about a situation with a bleeding risk. So what is your expectation here? Do we now get 10 minutes of music, or will it be a bit faster? Cheers. So you're good listeners. The dual checkpoint inhibition has a little less risk of the bleeding situation. And but of course, all these options are possible. In fact, we enrolled this particular patient in the Checkmate 90W trial. And the interesting question, of course, is what else would have been possible? I mean, we decided also because of clinical trial involvement to go for Ipi/Nivo. But could we have done STRIDE? Could we have done TKI?
Yeah, I think these are all reasonable. I would definitely try to incorporate immunotherapy if I can. See, the things that I think about when I'm deciding between the couple of different regimens that we luckily have now in the first line are tumor factors, patient factors, and then the social situation. So on the tumor factor side, I take a look at what is the patient's tumor burden, how large is the tumor in the liver, for example, what other sites of disease are there, is there what I call impending doom, is there a tumor that's going to press on a bile duct or the portal vein or something that's going to lead to complication. The patient needs a rapid response. So what's the patient's AFP to get a sense of aggressiveness? What does the last scan look like compared to the current scan? So all those are the tumor factors that we look at. Patient factors, as listed here, the patient had COPD. So taking a look at what kind of comorbidities they have. This patient also had varices, so that's something to think about. And then in terms of other patient factors, we look at liver function. So understanding what's their bilirubin, what's their albumin. There are different kinds of Child-Pugh-As, different kinds of A5s and A6s, so taking a look at that. And then last is the social situation, because if someone has an immune-related adverse event, are they going to call me? Do they have family support? Do they have savviness themselves? Do they live 3 hours away, or do they live 15 minutes away and they can come to our local hospital? So lots of different things go into making the decision around the different three regimens that we could use.
Yeah, I totally agree with you, Lipika, and to elaborate a little bit on some of these, major, determinant factors. One of the things also we don't take lightly in the decision of anti-angiogenesis here, which is also not only related to varices, but also related to the risk of bleeding from the big picture. And we learned that from our hepatologists and GI, that not every patient had the same risk, even with the same variceal grading, because some patients could have very low platelet count, 20, 30. So these patients are inherently at higher risk. Some patients could have main portal vein thrombosis, so mechanically that can also increase the pressure in the portal circulation. So all of these factors are also important to address, and for all of us, I would encourage everyone to kind of develop through your multidisciplinary team your own institutional algorithm based on what you have available, your resources. So that way, if you're not at the liver tumor board, if you're, the specific consultant is not there to discuss this issue, the team can follow this algorithm based on your own strength at your own institution. And finally, also, regarding the patient, the overall, picture of the treatment determination is the goals of care. So do you have an excellent condition patient, you're hoping for surgery, for example, in which case you really maximize your efforts to a point where you can even add local therapy to systemic, or this is a fragile patient with metastatic disease, child PUB, and the goals of care there is, as you mentioned, Elliptica could be goals of care, could be palliative treatment rather than curative options. So these things are really important also in decision making.
Yeah, I think cannot be stressed enough that the shared decision making, the multidisciplinary team, in the end is what is adding content and is resulting in the best outcome for these patients. Is actually also just look at our discussion, the fun part of the story, because this intercollegial approach is very rewarding. You're always learning something.
And of course, as you're saying, Peter, the shared decision with the patient, which I forgot to mention, just
Absolutely.
always, this is what the side effects are with this regimen, this is what the side effects are with this regimen, this is what the risks are. You could end up at the hospital more likely with this regimen versus this regimen. What does that look like, and how do you feel as a patient in terms of what option you want?
I always say when I talk to my younger fellows, if a decision is difficult, go to the patient. Mm-hmm. That helps, and then something which has been impossible to be decided is easy to decide. This patient developed endocrine disorder, as it's relatively frequent, hypothyroidism. And we have listed here, as a reminder to you, the NCCN guideline recommendations. You would want to put that on a larger scale and check whether there are other endocrine disorders, and if it's just thyroid, it's actually easy. We supplement thyroxine, and that's it, and control it by TSH levels. So that's relatively easy, and definitely not a reason to stop therapy. This patient showed a partial response. You can see this huge tumor was getting smaller, and that was actually an interesting situation, because with a partial response we would not have stopped treatment, but as this patient was enrolled in the 90W trial, where a requirement was the stop of therapy after 2 years, we stopped therapy. And this is the AFP development. Soon after therapeutic start, it dropped to normal levels. And then, and that's the interesting part, after the Ipi/Nivo treatment stopped, it maintained there and still is. So that's a very strong ongoing response and shows the potential of this combination. Now let's talk about the situation of a patient with a advanced stage disease, receiving immunotherapy and then progressing, and we have to be fair, most patients progress at some point. So what do we do here? In the good old days of sorafenib, it was easy. There were 3 or 4 trials showing what is possible in second line. I'll give that details in a minute. After atezo-bev, we do not have extremely developed evidence what to do next. I like the NCCN approach because it appreciates what the evidence is, Cabo and Rego here, but NCCN basically refers to whatever has been shown to be active in first line to be considered for subsequent treatment. This is very pragmatic and opens the door to quite a few immune combinations or monotherapeutic interventions, and some of them have been approved. And of course, there are always agnostic approaches where you can, if you have the genetic information, interfere, for example, when there's an NTRK gene fusion, and then you would have specific interventions here. This is the old data set. I'm not elaborating on that too much with respect to regorafenib, cabozantinib, and ramucirumab for those patients with high alpha-fetoprotein. There was a consistent, small but a consistent benefit for patients receiving that. It's now an unusual situation, of course, because we are much inclined to get started not with TKI but with immunotherapy. There have been approved immunotherapies, and that comprises Nivo, Pembro, and Ipi-Nivo from the different trials, if you have seen them in the past. And I'd like to ask another question in that setting. Assume you're treating a patient with advanced HCC, and we now specifically added it's an MSI high patient who progressed on sorafenib. Based on current evidence, how would you now treat these patients in second-line setting? And I would like to stimulate you to answer. Is it pembrolizumab, cabozantinib, regorafenib, or durvalumab you are using here in this setting? And please also consider to pose questions for the Q&A session later on. We already have 4. Yeah, I think it's very clear. Pembro and Durva in an MSI high situation would be a preferred option. Theoretically, everything is possible here again. Now, let's see what evidence we have in respect to second-line treatment. We have recently, in a consortial effort, investigated some 400 patients who received atezo-bev in first line, and then either got active treatment or best supportive care. A little bit more than 50% got active treatment, and active treatment was mostly TKI or IO. And the simple message is, if a patient receives treatment, it's better than supportive care, and if a patient receives IO, it's better than TKI. This is retrospective. This is not statistically in any way significant. It's food for thoughts. And of course, the hen and egg problem is not solved here in a retrospective analysis. Maybe just the better patients got treatment and therefore you see signals. But it might be a signal to be observed. Salvage, Ipi and Nivo after PD-1 ligand therapy, again mostly bevacizumab. You see from the waterfall plot that you can expect to see objective responses. Here they accounted for 22%. So IO after IO is working. And these are the old data from the Checkmate 040. You recall that there was a first and a second line post-sorafenib group, and in the second line post-sorafenib group, at least 14% showed an objective response, and some patients benefit for a long-term run. And another example, Ipi-Nivo after atezo-bev with respect to PFS and overall survival, and a 30% disease control rate, objective response rate, and a disease control in 40%. So IO after IO works, but we have not a detailed protocol here which could be recommended in guidelines. So as a summary, with respect to the second-line treatment options. In the good old days of sorafenib and lenvatinib only, we had defined options, at least for post-sorafenib. We are much inclined in today's availability of IO to definitely switch from TKI to IO. It's more complex if we have gotten started with the immune combos. Naturally, TKIs come into play here because it's a different mode of action, but as I have been showing, at least with respect to low evidence data, IO after IO is making sense, but the evidence is certainly not very strong. Let's return to our case. Patient received frontline immunotherapy, showed progress. And now what do you do with respect to this particular patient with respect to sequential treatment? Everything possible, or do you go to immune combos? How do you use the MDT here? Do you get started with additional local regional therapy? I mean, it's complex and easy at the same time. Everything is possible, but we have to talk about it.
Yeah, so this is a perfect, scenario for clinic. So in general, as you mentioned, Peter, looking also at the big picture again here and the goals of care. So a certain number of patients will have what we all call oligoprogression. So they're tolerating the treatment well, the imaging showing progression, but it is only one tumor or a new spot. So in these cases, we treat the oligoprogression and continue because clinically
pattern of progression, yeah.
Right, the pattern of progression is very critical. Also, their adverse events record. So what have they done okay on immunotherapy or not? If not, and they struggled, they went through steroids and all of that, so we know that we should probably choose another. And then again, as we discussed earlier, multidisciplinary discussion here, reviewing the liver function studies, reviewing the goals of care, and going back to the patient.
Absolutely. Yeah, after I've been doing a lot of talking, it's my pleasure now to hand over to Lipika.
Thank you very much, Peter, and thank you all for being here tonight. It's really an honor. I have to say, Peter and Ahmed and I have been doing CMEs for many years in HCC, and there's been a distinct difference in the last 12 months, I would say, in the way we do these CMEs, in that for many years, they really focused on systemic therapy in the advanced setting. And we had, sorafenib and lenvatinib and rego and cabo and all the things that Peter mentioned. And then we had all those second-line trials, and that's really what a lot of the CMEs focused on. But what we have seen over the last 12 months is that we're really trying to march systemic therapy up earlier in the disease for HCC. And so now when we do CMEs, there's 3 sections. There's systemic therapy in the advanced setting, systemic therapy in the intermediate setting, and then systemic therapy in the early stage setting. And so it's wonderful to see the progress in this field, and we thank all the companies that are committed to this space to be developing these drugs. So we'll start with a patient, a 44-year-old Asian woman who has chronic hepatitis B. This is a patient that I took care of in clinic. She presented with abdominal pain and BCLC stage B, or intermediate stage HCC. Good liver function, good performance status. Both of her lobes were involved, and she had multifocal disease, and she did not have any invasion of her portal veins. So the question is, in this setting, would you do liver-directed therapy alone, or would you consider doing a combination of liver-directed therapy and systemic therapy? So Peter, when you see a patient like this, what are the couple of things that you might think of when you see bilobar, multifocal disease, good performance status? How do you think about doing just liver-directed therapy versus adding systemic therapy?
It's an open question, yeah. The basic situation as we see it today is supportive of some proportions of patients have been including clinical trials with BCLC-B and showed better performance. But the true question whether you better do systemic therapy or the transarterial chemoembolization is absolutely an open one. Standard of care is TACE.
Yep, absolutely. So there's a lot of rationale for combining liver-directed therapy and systemic therapy. Of course, we know that in the advanced stage setting, systemic therapy has shown overall survival benefit. We know that potentially introducing systemic therapy earlier before the liver decompensates gives people a chance at getting the benefit of liver-directed therapy, because usually when people have intermediate stage HCC, we're not able to cure people with TACE alone, for example. Intermediate stage is often multifocal and bilobar, and so there's probably some spread through the blood or the lymphatics, decreasing progression to portal vein thrombosis and extrahepatic spread, and of course potentially increasing the chance of cure in the setting of using immunotherapy. And so many of you have seen this before. This is the 6 and 12 score. There's different flavors of stage B, intermediate stage HCC, and the question for the IR folks is, who are the patients that are going to benefit from the TACE and who will not? And so this is a prognostic score that was developed, which takes into account two factors of the tumor that impact prognosis. One is the size of the tumor, and the other is the number of tumors. And so the way you calculate this score is you take the largest tumor diameter in centimeters, and then you take the total tumor number and you add that together. So let's say you have 6 tumors and the largest is 5 centimeters. That's 5 plus 6 is 11. And so they've used this score to prognosticate, and they see that when people have a score of 6 or less, you can see that the median overall survival is 49 months. If your score is more than 12, it's 15.8 months. And so I want you to keep this in mind, because the trials I'm going to mention have been one of them has been reanalyzed using this score to see if it benefits patients in all 3 categories: less than or equal to 6, between 6 to 12, and greater than 12. And so this is what we call this is how we think about stage B. There's like good Bs and bad Bs, and it's kind of like getting a B plus, a B, or a B minus at some level. And so these are the different categories, and you can see all the way on the right, it's still intermediate stage, it's still multinodular, it's still confined to the liver, but there's just a lot more tumor burden. So, Ahmed, when you see these folks in clinic, do you think about good Bs and bad Bs, and do you think about how you give liver-directed therapy versus systemic, and how is it talked about in your tumor board?
Definitely, and this is one of the things that I always tell my fellows. This is not a tumor where you look at the report. You have to take it to the tumor board, look at it together. I would also add to the size and number the phenotypic appearance of the tumor, those encapsulated versus infiltrating tumors, hypervascular versus hypovascular. All of these factors really make a huge difference in determining what to start with. And finally, my rule of thumb usually is, if the IR are going to do the whole treatment in one session, that's the make or break. But if they're going to do it over 3-4 sessions, 2-3 weeks apart, then we know that those patients could progress in between. So bilobar, multifocal, innumerable tumors is different from just 1 or 2 tumors.
Yeah, absolutely. Those are great points. And so here's the continuum of, early BCLC stage B, often really focus on local regional therapy. When people have more extensive or later stage HCC, we focus more on systemic therapy. And the question is there a role for systemic therapy earlier on for BCLC stage B? And systemic therapy has demonstrated superior efficacy compared to TACE in intermediate stage HCC in one study of lenvatinib versus TACE. So we know there can certainly potentially be a role of systemic therapy in intermediate stage HCC. The 2 studies I want to focus on for this talk are EMERALD-1 and LEAP-012. Both of these are studies that had a positive primary endpoint with the combination of TACE plus systemic therapy. And the systemic therapy for the EMERALD-1 study, I'll first talk about the study population, because there were a couple of differences between EMERALD-1 and LEAP-012, which are important to know. So for this study, it was people with who had HCC that was not amenable to curative therapy. They all had Child-Pugh A or B7. LEAP-012 only allowed for Child-Pugh A. Patients here, they could not have had VP3 or VP4, but they could have portal vein invasion that was less extensive, so VP1 and VP2. That's in contrast to the LEAP-012 study, which did not allow portal vein thrombosis. And then, in both studies, patients had to have no prior systemic therapy or TACE. In this study, 4 TACEs were allowed. In LEAP-012, 2 TACEs were allowed. And so there were 3 arms here, a 1-to-1-to-1 randomization, where people got durvalumab plus TACE. In this study, when people were getting the TACE, they did not get any VEGF inhibition. That's a design difference also between this study and LEAP 012. So people got durva while they were getting their TACEs, or they got durva when they were getting their TACEs in arm B as well, or they got placebo when they were getting their TACEs. And then after they finished all their TACEs, which again was up to 4, afterwards they got durva plus placebo, durva plus bev, or placebo plus placebo. The primary endpoint for this was PFS. So it was positive for PFS. You can see here that the hazard ratio was 0.77. The median PFS in the durva plus bev plus TACE arm was 15 months. And when you had the placebo plus TACE arm, it was 8.2 months. And so again, using PD-1 plus VEGF plus TACE, that had a superior PFS compared to TACE alone. And so this is, one of the first studies to really show that adding systemic therapy plus TACE improves PFS over TACE. And it was not insignificant here, 15 months versus 18 months. The piece here, though, is that the OS data are still immature. So we can see that the lines are slowly starting to come together later on. So the question is, do we need to add these together, or should we do this sequentially when people progress after TACE? This is an ASCO update from this conference that was presented. This is the 6 and 12 score that I was mentioning. You can see in all 3 categories, when people had a score of less than or equal to 6, 6 to 12, or more than 12, you can see that that difference held in that people who got durva plus bev plus TACE had a better PFS compared to the people that had TACE. And you can see that the hazard ratio 0.69, 0.85, 0.61, relatively consistent across. And so the people who were in the plus 12 got the least benefit, but there was still a delta there. So now a question for all of you: which of the following characterizes the data that came out of EMERALD-1, the phase 3 study for patients with intermediate HCC? Was it that durva plus bev plus TACE was better than TACE alone? Was it that durva plus bev plus TACE was better than durva alone? Was it durva plus tremi plus TACE was better than TACE alone, or there was no difference in PFS? Yeah, so the first one is correct. Durva plus bev plus TACE was better than TACE alone in terms of median PFS. So the question is, at what cost? When we send people to interventional radiology, they can sometimes see interventional radiology once every 4 weeks or once every couple of months even, and they don't have to feel like a patient all the time. When you're adding systemic therapy, they have to come see Peter, Ahmed, or me pretty frequently as we give them their immunotherapy and potentially also a VEGF inhibitor, and then also for monitoring. So they are much more medicalized when we give them treatment. And of course, what are the side effects that we see? We see more hypertension, obviously, when you add a VEGF inhibitor. You see more proteinuria, and you see a little bit more liver decompensation. That was on the left is the EMERALD study, on the right is the LEAP 012 study. Everything in blue is where people got systemic therapy plus TACE. Everything in orange is where people got TACE alone. So you can see all the blue bars are higher than all the orange bars. Anything in the dark blue or the dark orange is the grade 3. I'm going to talk about LEAP 012 in a moment, but in LEAP 012, the rate of treatment-related grade 3, grade 4 adverse events was around 70% compared to 30% with TACE alone. So just think about that, grade 3, grade 4, 70% versus 30%. That's something that you have to really think about when you're treating patients in terms of, even though it might just be grade 3 hypertension, it's not life-threatening, certainly to talk about all the antihypertensives and, sometimes people come in to get 24-hour urine collections. So it certainly affects people's quality of life. So for moving on to EMERALD-3, the durva, this is a study that's ongoing right now, durva plus tremi plus lenvatinib. It's checking if you add CTLA-4 plus PD-1 plus a multi-kinase inhibitor that has VEGF-R inhibition. If you add that to TACE compared to TACE plus PD-1 CTLA-4 compared to TACE alone. So this will be another study that we'll be reading out. And then we have been using TACE for these studies, but of course in the US we use a lot of TARE or radioembolization. So there's 2 studies that are ongoing looking at systemic therapy combined with Y90, and these are both single-arm studies with different systemic therapy regimens. And there's a series of other ongoing clinical trials that are combined with liver-directed therapy. These are all different kinds of systemic therapies combined with TACE or Y90. And before we turn into the case, I just want to mention a few words about LEAP-012. That study was lenvatinib plus pembro with TACE compared to TACE with placebos. And as I mentioned, a couple of differences with that study were that there was no portal vein thrombosis in those patients. None of them had Child-Pugh B. And then lenvatinib was given during the period of TACE. And there are only 2 TACEs in that study. I think the combination of lenvatinib plus TACE may have partly been responsible for the higher rate of adverse events with that regimen, but that was positive by PFS. But then at the time of looking at OS, the hazard ratio was 0.08 and the p-value was 0.08. And the p-value for significance was 0.0012. So the preliminary overall survival data is not positive. It's still immature, but we're still waiting to see if there's an OS benefit. So coming back to the case, the 44-year-old woman who has the good performance status and the good liver function has the multifocal HCC. What treatment options would you consider? So Peter, is there a situation, like let's say if the patient had VP2 disease and fit into EMERALD-1, is she someone who you would give TACE and also add systemic therapy such as Durva-Bev?
Well, I'm conservative at that point of evidence. I do not see enough evidence to jump right into that combo. In the end, it's probably easy. In the end, there will be an ideal TACE patient, nice feeding artery, and you can easily capture it. There will be, with a very diffuse tumor, an ideal systemic patient. And then there might be patients where you can do either or. But for the time being, I would say we do what we have done and do clinical trials.
Absolutely. I also agree that it's helpful to see how people respond to the first TACE and then decide after that to do more TACE versus potentially switch to immunotherapy or a combination of immunotherapy and VEGF. Do you think EMERALD-1 or LEAP-012 are ready for changing clinical practice or not yet for your practice?
I don't think so, because those patients, as Peter was saying, some of them are very straightforward local therapy, so those should get local. The gray zone or the patients on the other spectrum, I still treat them with systemic first to start with, because of the additive toxicity. If you combine with local, we still don't have the evidence, and also because we know systemic therapy, especially the combo immunotherapies, can give 1/3 response rate. So you could save them having to go through local therapy. And I really think down the line, the intriguing thing is this study that we all wish to see mature one day would be for advanced patients, metastatic or vascular invasion, and then compare systemic alone to systemic plus local. We're all looking forward to that, because then you can really test this concept. If you do local therapy, even in metastatic disease, can you delay liver failure and offer survival advantage?
Absolutely. So follow-up polling question. So now after the discussion, how would you treat this patient with intermediate stage HCC, good liver function, good performance status, multifocal disease, largest tumor is 6 centimeters, no invasion of the portal vein? Would you do TACE alone? Would you do systemic therapy alone? TACE plus systemic therapy? And would the systemic therapy, if you did the combination, be checkpoint inhibitor or TKI? So looks like some people would do TACE alone, but some people are certainly convinced by doing the combination of TACE plus checkpoint inhibitor. So let's consider, let me go back, because I think I was, yeah, right here. So it's my pleasure to introduce my friend and colleague, Ahmed Kaseb, to now go on to the third segment of our CME, which is thinking about systemic therapy in early stage HCC.
Thank you, Lipika and Peter, and I really think you guys set the stage for this. So here we're talking about moving up therapy up to the very early stage patients. So those patients we consider curable with surgical resection, or in that case, also liver transplant category. So for those patients, the clinical dilemma is that the resection doesn't offer cure for every patient because the recurrence rate is very high. So with that, I present a case here, and this is my patient from clinic, 52-year-old man with a history of MASH-related cirrhosis, metabolic syndrome, obesity, diabetes, presented with large one tumor, unifocal HCC, 7.5 centimeter, with no vascular invasion, no distant metastasis. You see the encapsulation here and the hypervascularity on the arterial phase. Excellent liver functions, child PUA, and patient underwent resection. So what's next? Save your answer until the end, but this is the patient category, patient scenario that we're going to be talking about over the next 15 minutes. So first off, the early stage patients still harbor the common features, including the pathognomonic feature of the immune intense microenvironment. So we see here those categories: immune class 30%, intense infiltration of immune cells, immune intermediate, and then immune excluded class. And the 30% that really can explain to us why we have reached the glass ceiling, even with the combination strategies in HCC, to see this kind of response around 1/3 of the patients with immunotherapy, even with the combination strategy. So the goal here is, what can we do to increase the percentage of those patients in this category of favorable outcome to immunotherapy? Lipika talked about the local therapy. This is one of the approaches to stimulate the microenvironment with intense infiltration of cells and enhancing response. And surgery is also here. In this session, we're going to talk about surgery as a common local therapy approach. We used to think of it like before. So the guidelines for hepatic resection here for HCC patients are very strict, and that's because we have two disease states. Most of the patients will have some underlying chronic liver disease, and therefore we rely on our hepatologists to characterize their liver function status, also do upper endoscopy to characterize the portal hypertension. And based on this composite score of all of these factors, we decide as a team at the Liver Tumor Board if this patient can go for resection. So it's not one-dimensional chess. So you look here, the single nodules with any size, if the patient is in excellent shape, if there is no vascular invasion or metastasis, no clinically significant portal hypertension, normal liver functions, and with that, we can achieve 70% 5-year survival, and future liver remnant is also another major factor. So those patients with cirrhosis, they need 40% of future liver remnant. Despite all of that, the recurrence rate is very high. It reaches 70% after 5 years, 50% after 2 years. So post-resection recurrence rate is high, and it was shown in a lot of series and a lot of studies to correlate with things that Lipika talked about, the size and the number, and that makes sense because the more advanced the tumor stage is, the higher rate of recurrence because of the biology of the tumor itself. And then if you look at the strategies to apply adjuvant immunotherapy in HCC post-resection, we do have some of the key studies here, IMbrave050, and then we have adjuvant nivolumab, durvalumab, pimprolone, and then other Jupiter with the toripalimab. So there is a lot of adjuvant studies are still waiting to mature, results to be presented. IMbrave050 was the one that was presented multiple times. Initially, it showed a signal of activity. It showed significant difference in recurrence-free survival. However, upon further longer follow-up, the benefit was lost, and this led to failure of this regimen to reach clinical practice and FDA warning against use of atezobev in the adjuvant setting. And this is another adjuvant approaches here with the Nivo and Pimpro, 1-to-1 randomization. We're waiting on the results, eagerly waiting to see, although with the atezobev strategy, everybody's worried about this approach with the monotherapy. And then perioperatively, in terms of moving up the immunotherapy before either neoadjuvant alone or neoadjuvant plus adjuvant has been shown some nice signal. This is a study that was done at our institution doing nivolumab versus nivolumab plus ipilimumab. It's a small study, the signal finding, and showed both arms to have 30% major pathologic response. In fact, here you see 5 out of 6 patients achieving pathologic complete response with 100% necrosis, and you see significant correlation between the cytotoxic cells at baseline and response to therapy. And this is another codex analysis with the lymphocyte-rich microenvironment showing the same. So those patients specifically on the Nivo alone arm had to have had high percentage of cytotoxic T cells compared to T regulatory cells. However, patients on Nivo plus Epi didn't have to have this. So those patients had the benefit regardless of the baseline cytotoxic cell infiltration. This is an important analysis here, which pooled data from neoadjuvant studies in HCC. And the goal was to look at the major pathologic response, because some studies used 50% necrosis, 70%, even 30%. So the cutoff point here, the optimal one, was shown to be 70%. And you see here almost no recurrence and very significant survival. This is another approach with atezobev, 3 cycles followed by surgical resection. And that was done at our and this is atezobev versus atezobev plus tiragolumab. So this is comparing atezobev to atezobev plus anti-TIGIT here, and also waiting on the results to mature. This is Pimpro plus lenvatinib, a perioperative study just presented last year at the ESMO Asia. So you see here some decent response rates before surgery, and of course we have to wait for the longer follow-up. But this is also another signal finding here, and the median is still around 12 months. This is a study that was done at our institution with atezobev, 3 cycles followed by surgery, 13 cases resected, only 1 patient achieved major pathologic response, which was actually 100% necrosis, despite the response rate on imaging. So it shows some also discrepancy you see between imaging and pathologic response. And these are the key studies here that are in the early stage HCC. And you look at the regimens here, most of them are already approved for HCC and applied to earlier stages, either before or after surgery. So let's return to our case here. 52-year-old man with history of MASH cirrhosis. Just to remind you, 1 tumor, 7.5 centimeter, with no vascular invasion or metastasis, child PUA, platelet count is normal, and after resection, the big question is what to do for this patient. Would you consider adjuvant therapy? Is this patient candidate for immunotherapy versus treatment on a clinical trial? So I'm going to start with Lipican. Peter, what do you think?
Yeah, I feel the same way about this patient as I do about the patients with intermediate stage HCC, which is that there are a population of patients that are driving benefit that led to the improved PFS in Emerald 1 and LEAP 012, and in the improved RFS in the IMbrave 050 study. But we don't yet know who those patients are. And so to universally apply adjuvant therapy in the setting of high-risk HCC, I personally don't take that approach in my clinic right now. But I think what we can do is push as a community to identify better clinical biomarkers, better translational biomarkers that help us identify these patients better, so we can figure out who are the patients that are going to benefit from adjuvant. But I would not give adjuvant in this setting.
Right. And Peter, before you answer, what if I mentioned to you that this patient had alpha-fetoprotein of 50,000? Would you do anything before surgery rather than this case going straight for surgery? Would that make a difference in your management if you see features of more aggressive biology in terms of AFP or positive PET, for example?
So the problem is the need is there, but the evidence not. And in that situation, we cannot, on safe grounds, give recommendations. Of course, you can always titrate the situation. Young father of 3 kids, you want to do everything you can. And that's a situation where we do things which we are, where there's not the evidence we want. Alpha-fetoprotein is a prognostic factor and shows the differentiation. Could also use their clinical risk scores, and according to those risk scores, the range of recurrence is between 20 and 80%. You could use the 80% subgroup and do something. But again, I mean, this is the need driving the reaction and not the evidence. And I mean, officially, we would not recommend anything here. But involving the patient, surgical colleagues drive that decision quite a bit because they want to improve dramatically the prognosis. So again and again, we don't have the evidence. We hope for the evidence, and in individual case, you might do something.
Yeah, no, that's absolutely true. And to add, to the complexity of these decisions in clinic, sometimes we get pushed by the surgeons as well, right? So they call us, this patient, the alpha-fetoprotein last week was 20,000, today it's 30,000. I'm not comfortable taking him to the OR. So sometimes this also pushes us as a team to just take a consensus here and convince ourselves that there might be some more to this story than we see here. And that's when we do it off protocol. So the question about via clinical trial or not is also determined based on the immediate need and the available trials at the specific center. Have you guys run into this before to do neoadjuvant in these cases that you see something, jumping at you and the surgeon is asking for this?
Yeah, certainly with an AFP that high, I would suspect that maybe there's some portal vein thrombosis that we can't see on scans, or there's at least some micrometastatic disease that we can't see on scans. So with a shared decision with the patient, if they were willing to undergo systemic therapy first, I would certainly offer that.
What I would be inclined actually to do is rather a neoadjuvant intervention, because a neoadjuvant intervention has the beauty that it gives you a result later on. You see what you have been doing. If you start with sky-high alpha-fetoprotein, you see it dropping, and that would give you the information, there's something in the tumor biology where you can reach something. So neoadjuvant is probably without evidence better than adjuvant without evidence.
I totally agree with you, Peter. And actually, sometimes the major challenge here is the patient themselves, right? A lot of patients come and they want the tumor out. So this kind of discussion is very harsh with them. And sometimes I just have to tell them, if you're worried about progression while we're doing the 2-3 months of neoadjuvant, guess what? You shouldn't have surgery, because if you're going to progress in a couple of months despite treatment, that means you will have a rapid recurrence and it's going to be more aggressive. So a lot of times, especially for our young audience here, these things could help make the patients come to terms rather than the other way around.
Ahmed, do you ever use PET scan in this situation? If someone has a high AFP and they're pushing for surgery?
Yeah, so I've done it in a number of cases where it's borderline. If the AFP is going up by the week, we don't need to. But as you guys know, when you do this for a while, there is something. You look at the patient, and the patient himself is more symptomatic this week. So there is, even if the scan didn't change, AFP didn't change. So in these cases, I do AFP. So because if it is positive, we know, even from the transplant literature, that those patients are more likely to recur. And maybe, to Peter's point, maybe we can do some neoadjuvant to test the biology.
Thank you.
All right, so this
is getting back to me.
Yep, back to you.
you have a couple of take-home messages, and thank you for listening so far. I think you're aware that we do see quite significant advance in combination therapy, and that's the way to get started if there are no contraindications. There are 3 combinations available, and the problem is they have not been tested head-to-head. We'll come to that in the discussion, how to decide one over the other. That's difficult, and in the end, it's scientifically not sound. But yeah, there are some arguments, and we will talk about it. Sequential therapy is now, with the many options, getting complex. We will not see for every conceivable combination or sequence a phase 3 trial. So we have to gather what we have with respect to real-world evidence and rationale. The combined therapy evaluation is under the way. That was the point of Lipica, intermediate stage, systemic therapy, TACE, or systemic therapy plus TACE. And we've seen that there are many approaches to go into earlier stages with the increasing success of immunotherapy. And that is certainly something which will come. And on the other side, where systemic therapy is going to the left in the BCLC scheme, local therapy is probably going to the right, and in the end, it may be a mix. Scan the QR code to answer the final follow-up polls, and again, we are willing to take questions, and we would be very happy if you do the post-test evaluation. And if you are actively downloading the slides which we have prepared with so much effort. And some of them will be then winners. I'm not sure whether we do that now or at the end of the discussion. I think we just step into Q&A, and then we'll see later what's happening here. So we have a couple of questions. The most natural one is, how do you select between first-line IO options in metastatic HCC? Simple one, for you.
We'll certainly take a look at what someone's, the patient factors, the tumor factors, and the social factors, and then, shared decision-making. But certainly the comorbidities make a big difference in terms of what regimen I choose. Do they have any contraindications to getting anti-angiogenic therapy?
It's probably the easiest way to get started, talking about contraindications and toxicity.
Yes.
What do you want to avoid?
Yes.
Yeah.
So I think, at the end of the day, we all do cross-trial comparisons, but they were done in different years. Like Atezo-Bev was approved first, and then the Himalaya trial came later, and then the 9DW trial came later. And there were different drugs that were available as those trials happened. And so, when Atezo-Bev occurred, there was no approved durva-tremi, for example. After when 9DW was going on, after Ipi-Nivo, probably some of those people got Atezo-Bev, and did that have any impact on, the overall survival in the end? So I think, comparing overall survivals across the 3 studies, there's limitations to doing that. And also, Himalaya was going on during COVID, and there were fewer patients from China in that study and fewer patients with hepatitis B compared to the other studies. Does that make a difference in the overall response rate and the overall survival? So I think there's limitations of doing cross-trial comparison. So I think for me, I start with what are the contraindications to using anti-VEGF.
I appreciate that you are referring to the time trend, which is extremely impressive. We have seen in the SHARP trial 10-point-something overall survival for sorafenib, and later we went up to 15 months. Is sorafenib getting better over time like good old wine, or are we getting better in selecting and treating our patient? That's probably the point. In a similar way, the next question is, in what scenario would you certainly lean towards dual IO, so STRIDE or 9DW versus Atezo-Bev? Is there a significant proportion of patients where you go for dual checkpoint inhibition? Ahmed.
Yeah, so number one, of course, is safety for those patients. So if there is a contraindication to anti-angiogenesis, then the more complex question is the choice between Nivo-Epi versus Durvalumab. So you showed very nicely in your slides that those patients with the ALBI score 2 and 3 still benefited and went through therapy safely. So there was another study done for Atezobev with the ALBI score that didn't show that. That showed that patients did poorly if they were ALBI score 2 and 3 versus 1. So I tend to, for those patients with Child-Pugh B7, so Child-Pugh B, B7, I tend to use less of Atezobev if I can use Durvalumab. And now with the Nivo-Epi, the main advantage over Durvalumab is the response rate. Also, there is some survival benefit. So if the patients can handle it, then we can approach it that way, that if now they have to get immunotherapy alone and the choice is between these two, so goals of therapy again, are we looking for response rate? Are we looking for, patients with, good ability to tolerate nivolumab, ipilimumab with the high dose of epi and go through certain treatments like steroids? So these are the factors. And as you mentioned, Peter, also talking to the patients about this possibility. You have higher percentage here to be on steroids than the other regimen. And overall, the goals of care, as we talked about, are you trying to make them surgical or transplantable? And to this point, Peter, I think we might need very quick comment from you as a transplant hepatologist for those patients who potentially could go for transplant and immunotherapy and when, to stop and all of, because these also, I think that a lot of people have it in their mind.
That is actually a very complex question because the one thing which a patient would be benefiting from is transplantation. In oncological terms, with respect to the time span the patient wins, even though recurrence occurs, and which is actually then easier to be treated in a transplant setting. So it's, however, highly regulated. In my country, for example, if you are out of Milan, you are out of Milan. And downstaging is not considered. In the US, downstaging is an option, and it's probably wise to do so because it's a biological response, and these patients are good patients for transplantation. So, simple answer here, whatever you can do if you get a patient into transplant, patient will have a couple of years, even in terms of recurrence. Yeah.
And how long do you stop immunotherapy before transplant?
So if we can calculate it, then we suggest 3 months. But this is in my country where the waiting list is long and it's difficult to plan. In countries such as Spain, where you can reliably predict that if you put a patient on a transplant list within 4 weeks, you get a transplant, then you can make plans. We can't. Yeah. How do you do it?
Yeah, the same thing. I rely on the hepatology team and the transplant team to tell us, so sometimes, they have 6 months imposed on them here in the US before they can, list. So they tell us that now we put the patient officially on the list. We need to stop immunotherapy because it could happen within 3 months. So here we go by 3 months as well. And the clinical dilemma is once you stop immunotherapy, and we know some of them will have to wait 3 months plus, do you start anything maintenance? So this is something we're grappling with, and some of us would do TKI as bridging maintenance therapy.
Peter, can I make one more comment about the selection of frontline therapy? I think one thing that 9DW changed was it reinforced that when people get a CTLA-4 antibody, people can have long-term durable benefit. 9DW read out after a couple of years of follow-up. And so it showed that proof of concept of what we saw with STRIDE, that when you add a CTLA-4 antibody at 5 years, 20% of people are alive. And so I think when Atezobev and STRIDE were first out there, I think many of us used Atezobev as default, and then if they had contraindications to getting a VEGF inhibitor, then we would use STRIDE. But I think 9DW is changing the game. I think the fact that there are a lot of long-term survivors with either of these 2 dual checkpoint inhibitors, I think there's a little bit of a turning of the tide where Atezobev is still an excellent regimen, but I think there's a significant rationale for using dual checkpoint inhibitors, whether or not someone has contraindications of VEGF inhibitors because of that long tail that we see.
Yeah, it would only be possible to make a clear-cut decision here if we have long-term survival data for both protocols and other aspects such as conversion to resection or transplantation and to go from there. But I would agree, I mean, intuitively speaking, this sequence of priming, CTLA-4, and then immune evasion, killing, that makes intuitively sense. It's I think the only way to overcome a cancer is always the immune system. So I would trust IO and double IO more than mono IO, that this is the most important thing we can do, and the rest may be additive.
Yeah.
But this is, let's say, an emotional, not an oncological explanation. A good question for you, Lipika, because you have published prominent papers on genetically tested cholangiocarcinomas. A role for molecular testing in HCC?
Yeah, I'm doing it more and more personally because there's different targeted therapies that are being used in HCC. For example, FGFR4 inhibitors are now being used in clinical trials for patients who have FGF19 amplification or overexpression. There's now trials for patients with beta-catenin mutations. And so I think more and more there are clinical trials that are available. So my preference after a frontline therapy for HCC is to actually put people on a clinical trial as second line if liver-directed therapy is not a good option for patients. And so I have found myself doing it more and more recently.
We have a question from Eduardo.
Hi, good evening. My name is Eduardo. I'm from Brazil. I have a question. Do you go back in BCLC according to response to the treatment? Because I have some case in my clinic that responds well, and we discuss SBRT, TACE, and transplantation. How do you deal?
So a patient who responds to therapy unexpectedly well, and there is a downstaging situation. I mean, this is particularly pursued in Japan, where it's actually purposely induced by getting started with systemic therapy, atezo-bev, seeing a partial response, making this response more complete by additional ablation, and then use the new BCLC stage for a new decision, resection, for example. That is, of course, not supported by high-level evidence, but doable in individual patients, yeah.
Yeah, and I would just add a little, point to that also go back to the liver tumor board and look at the pattern of, the disease. If you still are seeing partial response, the tumors are still going down in size. If you're still going down in size, wait until you get the plateau. And once you get the plateau, if there is active disease, hypervascular and the imaging, then you can approach, because I have seen some patients actually go into almost complete remission. There is no hypervascular tumors, AFP is normal, and they're still worried about some area remnant there. I wouldn't worry about the remnant unless it is an active disease.
How do you approach early stage HCC follow-up and monitoring? An open question, no data to get started with, but how we do it.
People who have high risk features on their path for HCC and they've had a resection, I will often do every 3 months for the first 2 years and then switch to every 6 months. For people who have relatively low risk HCC, I will sometimes do just Q6 months and follow them for 5 years. But certainly what kind of conversation with the patient, what they feel comfortable with, but that's generally my approach. And I check AFPs if it was relevant for the patient.
Yeah, I agree, and I've seen some, some studies evolving. Hopefully next year we see some ctDNA like the colon, story and so on. But up until this point, we go by this standard, approach, which is also in the algorithms everywhere. Do you guys in Europe, do you do it the first 2 years every 6 months or every 3 months?
We have no standard recommendation. So we do it in an individualized protocol, and that is between 3 and 6 months.
Yeah.
Can we restart immunotherapy at disease progression if you have stopped the treatment after 2 years?
I have
Restart
certainly done
definitely is
that.
possible, yeah.
I have certainly done that, yep. Especially if they had a nice response and have benefited for 2 years, and then maybe at 4 years they have progression. Depending on the nature of the progression, I will first think about, can I do surgery to resect a small new liver met, for example, or do any kind of local regional therapy to try to cure them. But otherwise, yeah, I've definitely started immunotherapy again if people have multifocal recurrence.
We have reached the end of our session and I have still many questions. Thank you so much for sending them in, and I really feel bad for not being able to answer all these questions, at least not here from the podium. But it tells us there's a lot to be discussed, and that will continue for the next years. Please stay tuned, load down the slides. And I think we are now at the point where we can define winners. And I think that's happening when you look at your cell and you see a winner sign that $50 and 25 always go to the faculty. So thank you so much, Lipika and Ahmed. This was, as always, great. I could have gone on for 3 more hours. Thank you for being interested in our topic, and enjoy ASCO. Good night.
Thank you, Peter. That was